Well, welcome to Disruptors at Work, an integrated care podcast. I am your host, Dr. Cara English. I'm the CEO of Cummings Graduate Institute, and I am really excited today to be joined by a new guest, Napoleon Harrington, who is currently a student in the Doctor of Behavioral Health program at Cummings Graduate Institute. Napoleon has a lot of great professional experience in advocacy in the professional organizations, and he is actually a founder of his own organization called Ambassador Counseling and Resource Group, which is a clinical mental health practice that offers therapeutic services for children, families, and adults. He also serves as an adjunct faculty member on topics related to psychology, mental health, and human services. And Napoleon has been recognized by civic organizations and by government officials. And in fact, he recently in 2020 won the Mental Health Counselor of the Year award. So we are excited to talk with him today to hear more about that award and about the leadership. He is the past president of the Michigan Mental Health Counselors Association. Napoleon is currently living in Auburn Hills with his college sweetheart and wife, Faith, and with his 18-month-old twin daughters, Isabella and Imani. So welcome to the podcast, Napoleon. I'm really looking forward to hearing more about you.
Yeah, well, thank you very much. I'm really excited to share. My DBH journey has been outstanding so far, so I'm very excited about becoming a disruptor in the future. And apparently I've been a disruptor all along in disguise, but now it'll finally be manifested. So so I'm excited to be here.
I'm so excited for you to talk a little bit about the Mental Health Counselor of the Year award. Can you tell us a little bit about that? And please feel free to share about what that was like earning the award in such a challenging year for mental health.
Well, I'm humbled to have won the award number one against many of my colleagues who have done some remarkable work ranging from research to developing new kinds of therapies, et cetera. But to be recognized in 2020, which, as you mentioned, pandemic year and had been very critical in mental health, I was very humbled to have won the award. It was presented by the American Mental Health Counselors Association, who represents professional counselors across the nation. And I was awarded it. They did a ceremony in June, and I was able to virtually accept the award, which was a first. And it was exciting to accept. And one of the first things I could only think to say is that this award is not mine alone. It is in conjunction with everybody who has ever invested anything in me. And also more recently, for the work that we were able to do at Michigan's Capitol, producing legislation, that team were very critical. And I just happened to be a guy in the right place at the right time, willing to try. And so I think that's I
think you might be on the verge of being a little too humble there. But I appreciate, just the fact that you noted that it takes a team, because oftentimes in our profession and in the world, we do see one person who's being awarded or one person who's being highlighted, in the news or in the professional organizations. And the work, though, is really based on a team. So I'd love to know a little bit more about the team and about the legislation. Would you mind sharing a little bit about that with us?
Sure. Many of us growing up, and I might date myself a little bit, only watched Schoolhouse Rock and knew that much about a bill. Yes, I'm just a bill sitting on Capitol Hill.
All sing that song. Absolutely.
Exactly. So that's pretty much what I knew about it. I was not very involved in politics initially at all. And to this day, I'm still not really. But it does take a really strong understanding of how political processes work in order to produce a bill. And so at any rate, the Michigan professional counselors had to address a couple of things that were going on with our scope of practice and with the work that we do. And so we needed to make sure that it was codified legally, how we do the work. So not to get too far into the details, but what we chose to do is we produced some language to address some of the concerns that the Department of Licensing and Regulatory Affairs had with our current bill. And because the department has one job, which is to make sure everybody's in sync and they're doing the right thing, they added just the right amount of pressure for us to put the bill together and make things work. Well, as we've been working on this for years, to say the least. I was president for 4 years, and the normal term is just a 2-year turnaround, but got reelected in order to kind of finish the job. And so I guess the long story short, but it's a very long story. We started many years, actually preceding me, actually. There was a team of Jim Blundo, Sarah Schaefer, Irene Amatrano, and a couple of others who have been putting together some really significant language to address the bill. And because the bill had been addressed, but the Department of Licensing and Regulatory Affairs was not necessarily satisfied, we had to go back and forth and back and forth. And the clock was ticking, and some glitch in the system is what we'll identify it as. Some glitch in the system made it so that the clock would actually end on our ability to produce our answer to the concerns that the licensing and regulatory group had. And what it would have done is severely limited our ability to practice. It would have disenfranchised at least 10,000 counselors and hundreds of thousands of folks who depend on those people to provide services.
Right.
And so the long story short, again, is that we mounted one of the largest, and it kind of brings chills to me again when I get a chance to talk about it. Legislators at Michigan's Capitol said that we mounted the largest response that the Capitol has ever seen. And it came from a group of licensed professional counselors and other mental health supporters. We had thousands of people who literally came to protest at the Capitol or showed up to speak, and all off the initiation of the work that we had been doing to produce the answer for the Department of Licensing and Regulatory Affairs. So it started off as House Bill 4325, and it was codified into law, PA 96, in 2020. I'm sorry, 2019.
2019. Okay.
2019. Yeah.
And so can you tell us, is the legislation, aimed at licensure for mental health counselors and the licensing board requirements?
Yes, it is. It was primarily to make sure that we still had the capability to diagnose, and in terms of looking toward the future, the idea of portability, we needed to make sure we cleaned up the language to ensure that the efforts towards portability would be successful in the future, and we needed to clean everything up. So it was a big fight, and a surprising fight. And most counselors, as we were kind of chatting before we got started with this, most counselors kind of take the I'll just sit back and watch approach. And the conversation toward advocacy, it got a lightning storm happened in Michigan. And so I'm very proud of the team, and we were able to mount something really special, historic, in fact. And there's some conversation that we were able to really save the profession in the state.
Yeah, that's an amazing accomplishment, because you're right, it is very difficult, even in the best of times, to mount or just to bring people together to, catalyze that kind of advocacy movement. Like you said, people are very hesitant to get involved. There are lots of worries, especially among counseling professionals, towards their licensing boards. Many people are very afraid to be on the radar. That's definitely something we face here in Arizona, because boards, traditionally have not been there. Licensing boards aren't there to support professionals. They are there in by governor appointment to protect the public, and they've
Mhm.
taken that to be very punitive
Mhm.
in scope. And so it doesn't take much to get on the radar in some states, and so people will really avoid that at all costs.
Mhm.
So tell me a little bit about the strategies that you and the team used to get that kind of engagement. And I'm imagining that it must have been incredibly difficult, but was any of it done during the pandemic, or did it all happen prior to the pandemic?
It's Timing is amazing because it all happened pre-pandemic. Because if it would have happened during the pandemic, I'm not confident that we would have been able to successfully do what we had done. And so some of the strategies that we were able to use, I think the first one is being able to pull together a team of people who were very conversant in things like law,
Yeah.
um, people who understood political process, also people who were very content experts at the practice of counseling. um, that was very critical because you get those minds in the room and you're able to shape a conversation that in layman's terms people can understand, whether they're if you're from a political background, when they were able to read the language that was produced from the political ease perspective, they were able to understand it. All of the professional counselors that read it, or mental health professionals that read it, understood it because it also had their language in it. So putting together a team of minds in the room that were very clear about their role.
Mhm.
The other thing that was really important, social media, it's one of the greatest distractors in the universe, but it is a very useful and powerful tool. Psychologists say that it's a paradox of progress. It can divert you, but it can also really help you mount one of the largest campaigns that you would ever need. And so our conversations went viral. I would make videos, others would make videos that would basically give marching orders or tell people what should be done or what is actually happening. And so that was important, a very good social media strategy. And then just the sheer idea of being consistent with a message. We would really hold close to the chest what messages needed to be produced at specific times. And if everybody in the choir is singing the same note, my goodness, we sound great. But if we've got everybody in the choir singing something different at different points and different times, well, then we sound disjointed, which makes it very difficult for our cause to sound believable.
Yes, that,
So,
oh my gosh, I'm so glad that you mentioned that, because I think that's something too that a lot of people don't understand, is that
mhm,
while the group itself may have a lot of different messages that they want and a lot of different voices that want to be heard, if the message isn't clean, clear, and concise enough, it is not ever going to be communicated in a way that can be used for policy purposes.
yeah, and we had some difficult times with other counseling organizations that were with us, because they would wonder, well, why aren't you giving us the information? And it was very strategic, and it was no disrespect toward the organization, but it was really about making sure that the right message got across. And thank goodness it happened, because we were able to successfully pass our legislation clean without any objections through the House, through the Senate, through committee meetings. It was a chilling, wonderful sight to see. We had an amazing firm that was there to help support us. Acuitas and Andrea, who we call Saint Andrea now, because she just worked her political willpower and magic on Capitol Hill, and did a fantastic job.
Mhm. It's really a beautiful story. And I can think of so many different, policies that are needed,
Mm,
uh, state level, federal level, that it would be a beautiful story to be able to put that model, the model that you used, into practice, because I don't think there's an American or, a citizen anywhere in the world who can say that there isn't a need for healthcare improvement, whether you have, third party system like we do, or a national health system like many of the European countries, Australia, and Asian countries have. There's always an improvement that can be made. And I don't think that there is a lot of involvement outside of the professional organizations. Even if you're a member of a professional organization, I don't think there, like you said, I think a lot of professionals are like, I'm busy enough, I don't have time, and I don't like politics, so I don't want to be involved. But just as your experience exemplifies, there are so many times where if you don't show up, you may lose more than you're about to lose in being able to treat patients effectively using the science and the evidence and the research that is best practice and needs to be applied.
Absolutely. I can't tell you how many times we would go into meetings and have the DSM right next to us and have other materials that verified the work that we do. And as you spoke to research, I mean, the research was critical to help to advocate our points. And so it was just it was an all-out effort. And it was great to have the support of even non-mental health professionals that would be there to support us. There were plenty that went against our cause, but they have their right to. And it just demonstrates that our evidence was strong enough to discredit any point that would attempt to take away our ability to diagnose, et cetera.
Yeah, and I think that's a good point too, because anytime you're looking at policy, there will always be those who disagree with what it is that you are trying. They'll find a way to pick it apart. But if you lean heavily on the evidence to support your cause, it's not opinion. It's not, the whole facts over feelings, feelings over facts dynamic. It really is rooted in science and best practice and best health outcomes. If you can make your argument strong enough and you have the support of a well-oiled machine behind you, it sounds like you really found the keys to success. So I'm really happy for you guys.
Yeah. Well, thank you for that. And the ironic part of that is the machine was very small. It was a very small machine, and it taught me a whole lot about. It kind of gives me the David and Goliath feel. It taught me a whole lot about being able to respond to major events with just a few committed individuals. I think Margaret Mead said something about that a few small committed individuals never underestimate what they can do. So I'm eternally grateful for the efforts of the folks who helped to put together this whole response. And a lot of Michigan mental health folks are remarkably happy now.
Well, I'm glad to hear that, because goodness knows that due to the secondary pandemic of mental health that we're now facing, and certainly substance abuse combined, and included in that secondary pandemic, we really need as many high quality, well-trained mental health professionals and advocates as we have available. And we really need for insurance companies to remove and be looking for access barriers that they can remove. And so, if it's an issue of scope of practice that needs to be removed, outside of Michigan, that really needs to be addressed. Tell me a little bit about nationwide. Are there other states that have legislation similar to what Michigan was able to pass?
So at this point, I'm not very sure about who's the national landscape, because things have shifted so much and priorities have changed. I know that New York had some legislation that was, it always seems like New York has always got some legislation that from a mental health perspective is waiting to be addressed. I also am aware that, I believe it was Florida that the Florida Mental Health Counselors Association was working very diligently on some of the same things. But the landscape has shifted so much because of the pandemic or post the pandemic that now we're really focused on kind of making sure parity is happening on a more consistent basis. And of course, parity it's a big conversation because the myth out there is that we don't do the same thing as our counterparts who may have been trained maybe 2 or 3 classes differently, but we do the same scope of the work. And so we're looking for parity to make sure that third-party payers respect the work that we do. Right. So yeah, parity is probably the biggest point of reference for us now, and portability.
Right. So for those listeners who aren't familiar with the term parity, it really is a term that is applied to mean equal reimbursement for a healthcare professional. For example, for a mental health counselor license, would receive from a third-party insurance or from CMS an equal reimbursement amount as other licenses. So this is parity has been something that has been addressed by mental and behavioral health professionals, including psychiatrists and psychologists. I was talking with you, Napoleon, about my experiences as an undergraduate student working for the Arizona Psychological Association in the way back in the 90s. And, driving down to the state capitol and picking up legislation and bringing it back so that the board of directors, including psychologist members from Arizona, and the executive director could, edit and provide their input into the legislation. And it really impressed upon me at the time because parity was a huge issue for psychologists. Those were the days when equal or even inclusion of mental health benefits in third-party insurance plans was not assured. It was not mandated. We now, of course, have federal mandate for parity, equal coverage for behavioral health and substance abuse, as well as physical mental health coverage. That doesn't, however, mean that we get that. And so one of the ways that parity is still a major issue for mental health and behavioral health providers is the bickering between, well, what license should be paid what. There's also, of course, a lot of differentiation between the physician rate for services. For a 15-minute episode of care for a primary care physician is it can be close to 3 times the rate that a mental health clinician might get for that same 15-minute episode of care, even if both of us are coming from the doctoral level. So it's really still a huge challenge for at a lot of different levels, and depending on the way that parity, the word, and the federal legislation is interpreted by third-party insurers, and whether or not there are professional organizations, like you mentioned, that are maybe seeking different aims. There are professions that want to protect their slice of the pie, and that really hurts patients because there are always going to be an unlimited number of patients who need mental health care. And there are literally unlimited pies. If we can just stop looking at it like, well, we need to protect our slice, you will literally have unlimited slices. Why not allow unlimited mental health provider access, as long as we've, met our continuing education standards, our licensing standards? Why would we place a lid on that if we continue to have access barriers nationwide? So yeah, parity is a big issue. I would love to hear more about portability, because this, especially during the pandemic, became an interesting issue with telehealth. So again, for those listeners who may not be as familiar with what we've been seeing over the past year, we saw telehealth being an approved mechanism of service delivery, whereas in the past, prior to 2021, there was really just no ability to get reimbursed, or very limited and really legally and professionally tricky. It was very tricky to be able to provide or deliver services via telehealth for medical and for behavioral health providers. But thanks to the pandemic, we were able not only to have access to continue service delivery via telehealth, but also to prove its worth in, managing and maintaining health, mental health, as well as physical health. So I'm wondering about portability, just from the standpoint of what that means to some, is that you are able to be in your state. I live and work in Arizona, and I might have a potential patient call me from New Mexico and ask for a telehealth visit. Prior to the pandemic, no, that was a hard no. You cannot practice even via telehealth, even if your practice is 100% telehealth in your state. And it's the exact same thing, seeing a person in New Mexico versus seeing a person in Arizona. And so portability has been an issue with both telehealth as well as a physical practice. So for example, if you're a mental health worker or a physical health provider, and you want to respond to a crisis, and one of the ones I use a lot as an example is, Hurricane Katrina, or the one in Houston. I can't remember the name. There are so many hurricane names. But if you wanted to be able to respond outside of your state, we're limited in scope of practice to just the state we're licensed in. So can you share a little bit about how the Michigan Mental Health Counseling Association is addressing that or addressed that with the legislation?
Yeah, well, it's been directly, but not through the conversation of portability. It's been by cleaning up the language in our bill, and making sure that if anybody picks up our bill and reads what we do, how much does it mirror what other states say that their professional counselors, even if it's named something different, which is a challenge for professional counselors across the board, do we do the same things, so that we can easily kind of swap out our roles? So I think the primary way that we've done it is through consistent legislation, and staying on top of what we can manage here at home. But we've also been relatively involved at the national level with the American Mental Health Counselors Association. I've served on a few committees, and our executive director, Jim Blundo, had at one point been president of the American Mental Health Counselors Association. So keeping our ear to the ground of what's happening on the national level, and contributing the Michigan voice, if you will, to what kind of things we're seeing and what we're hearing, and how that could help shape the national conversation. So portability, it's kind of one of those hopeful markers that we're running towards, because we kind of have an image problem from a professional counselor's perspective that we've got to work through, period. And it's primarily, what language are we consistently using as a practice or as a profession? An attorney when an attorney starts talking, a mechanic when a mechanic starts talking, because their language sounds the same. Do professional counselors have the same language? Are we using the same kind of phrases and words like we're being trained in our DBH to do? So in essence, we've got to do that. And then we've got to clean up what we're called across the board. Even if there might be a variation of one word or two, that can sometimes severely confuse people. So are we licensed mental health counselors, or are we licensed professional counselors? Is one the actual license, and is our title something different? So being able to clean all that up first, and I use the term, and Mom did this to me, we got to clean the kitchen first before we invite guests in.
Right.
And so basically, if we can get that kind of thing cleaned up within our profession, then it helps to make it a lot more consistent to get the support or the advocacy that we need from the people that we're appealing to, or stakeholders.
Absolutely. And, you and I were kind of talking a little bit prior to beginning recording here about, the need to really look at how to do that as doctors of behavioral health. Because while there are and have been a couple of professional organizations that have been established, none of them have yet gotten really the penetration of awareness among DBH professionals in terms of membership And we really just don't have yet that advocacy in terms of a professional organization to help us clean up the kitchen.
hmm Yeah, and I think once something like that happens, I mean, we've got a group of cheerleaders in our program already that are ready to beat the drum. But what would happen if we had a corporate drum that we were all beating, and that unison of that voice would announce that DBHs are coming, and it wouldn't be a surprise that you would have a DBH sprinkled here or a DBH sprinkled there. We would have actual integration teams looking for DBHs to bring them onto their teams or their organizations. And so I'm a huge fan of seeing us being able to advocate for ourselves and just kind of let everybody know, hey, we're not just that we're coming, but we're here, and how important that is.
Yeah, I had a really interesting experience during the pandemic. I attended a virtual conference. It was a national conference. 2020 Mom is a national organization that does a lot of advocacy and continuing education around maternal health, maternal mental health, and maternal mortality and morbidity across the United States. And I attended their 2020 virtual conference. And one of the first sessions that I attended had a panel. And one of the panel members introduced herself as a doctor of behavioral health. And I just about fell out of my chair. I thought, oh my goodness. Here's a woman I don't know who's a DBH, and you and I know that there aren't a whole lot of DBHs nationwide. So when you meet one who's actually presenting at a conference you're attending, that's a big deal.
Yeah.
Yes. And since that time, we've connected further and had some good conversations. She actually lives here in Arizona, my same state, and so we've had some good connections and some conversations about how to really increase awareness of ourselves in the state of Arizona and what we can do for our state in terms of healthcare improvement. Both of us are working at the policy level with the Arizona Department of Health Services. That is really a role that, as a clinical training program, most training programs for behavioral health really miss out on the entrepreneurship piece, as well as the policy and legislation piece. And this leads back to the, I don't like politics, I'm gonna, see what happens kind of approach. And as you know, in the Doctor Behavioral Health Program, entrepreneurship is one of our 3 pillars. But for the last couple of years, I've been saying we really need a 4th pillar, which is, policy and advocacy. So tell me a little bit more about how you see doctors of behavioral health contributing to policy and advocacy for healthcare improvement at the state and federal level.
Well, one of the main things that I'm noticing as a finishing first year student is we have a very dynamic role in any integrated system. We have the ability to not only stretch across one discipline to the next, but we also have the ability to kind of stand alone in our own as well, which kind of serves in a very, we create a vacuum in a way that integrated teams would be very, they would love to have. So I see us in a way being able to use what our, the core of our training to not just educate, but to make sure those conversations related to parity are actually happening.
Right.
Not only that, also having the ability to be the content experts on all things that are behavioral health. Because as the shape of third-party pay continues to change, and it will always be dynamic, it seems to fit the work that we do, and we should be able to speak to the concerns that they have. So we would probably be one of the best suited folks to consult with third-party payers on how to approach certain conversations. And that's one of the things that really impresses me about the program is the conversation. I'm clinician driven primarily, but this whole conversation related to consultancy has really just blown things up for me. And I'm really interested in that. I'm still clinician at heart, but that consultant piece is very critical, particularly at the political level, because we live in a society that is governed by policy.
Right.
And because we're governed by policy, it's important to be able to have content experts should be holding the content expertise. And so our contributions to that conversation to policy is very critical.
I absolutely agree. And I really like the idea of going back to your statement about being able to look across professions. We kind of are an interprofessional professional
Yeah.
because we do have the training in medical literacy for, most behavioral health clinicians. They may have had some small amount in a training program, not likely because the, standards for NBCC have not changed. And are unlikely to change unless we do something about that. I think most consumers of mental health services would like to believe that their therapist knows something deep about a medication that they've been prescribed. And we, in our opinion, should. And that's why medical literacy is one of our 3 pillars in the DBH program. And behavioral health interventions, of course, that's our 2nd pillar, and that really speaks to the clinicians at heart that we all are. And then our 3rd pillar, of entrepreneurship, being able to just even have those 3, which some people see them as mutually exclusive, the idea of being a clinician and being an entrepreneur. Before I became a DBH student, I really did not understand that I was an entrepreneur. I understand that entrepreneurship just simply means finding a need and filling it, and that can encompass healthcare improvement in a huge way. And I agree with you that, sort of that vacuum idea of, being in the room with an interprofessional group, it really, everybody else kind of looks like, well, somebody should do something about that, or what do we do about that? And as a DBH, I guess what I learned is that I'm usually the someone, and I'm usually the person who can help the group come up with the what.
Yeah. Because when you have psychologists in the room, psychologists speak from a psychological perspective. When you have professional counselors in the room, they speak from a professional counseling perspective. But what somebody who's probably in general society is thinking about, they're just thinking about behavioral health or mental health. And they don't want to know what each facet is saying. They want to know what's the general conversation. And so as DBHs, we hold the content expertise to be able to speak to that direct need. So we kind of cut out the middlemen, which I got to say that carefully, because if it wasn't for us middlemen, now we wouldn't be able to get this policy stuff taken care of. But as we grow the DBH population, they become very critical to like really linchpins to the conversation.
Yes, absolutely. And I think too, being able to, we have such a strong patient and family focus, patient-centered care, family-focused care. So, across the program, our conversations tend to go, well, what's the best thing for this patient? What's the best thing for this family? And yes, we have to have a mind to the bottom line. Otherwise, we can't keep serving. So yes, but we will not let the bean counter, which is, the person designing the algorithm to make sure that the company is profitable, tell us what is best for the patient, because it will almost never be what is right for the patient. And it will almost always be what is just best for the bottom line. And those two might be diametrically opposed.
Which is
part of it is just making sure we have that really strong voice of advocacy for patient-centered, family-centered, or person-centered care, depending on, where you're coming from, as part of that professional group. And you're absolutely right that we are likely the best person to be consulting with third-party payment systems, and certainly with CMS as well about, what it is that is best. And we can definitely do that from a population health perspective as a DBH. And I think that's something else that we were really missing prior to entering the program. I know I never had any education in population health management or a stepped level of care, to be able to design that prior to becoming a DBH.
Yeah. And as a practitioner, another critical piece of that conversation is the whole return on investment. Practitioners don't necessarily consider return on investment a very important part of that conversation, but it's what drives healthcare. And so the DBH, as the emphasis is placed on ROI, we're really, we're also able to speak to that because it's at the forefront of our training, and it's really a key element to making any policy and policy kinds of decisions. Yes, protect the public for sure, but we also need to make sure that we're managing the dollars of our municipalities appropriately.
You know, that's such a good point too. And I think it has been left out so often. One of the things I remember Nick Cummings saying at, and for those of you listeners who don't know Nick Cummings, he's, you know, the founder and the visionary behind the DBH program, as well as, you know, really the idea of healthcare integration, you know, looking back into the 60s and 70s, you know, for primary publications on medical, or excuse me, in the 80s for medical cost offset and return on investment publications, Nick Cummings really demonstrated the benefit of having a hired, you know, possibly even full-time psychologist or behavioral health provider working in an integrated way with primary care or specialty medical care providers. Not only does it pay for itself in terms of the position because of the reduction in unnecessary medical procedures and tests that are related to the lack of education and training that physical health medical care providers have in diagnosing and identifying a mental health condition that is exacerbating a physical condition. But, you know, so not only can we pay for our own positions with the reduced medical costs, but we also are improving healthcare outcomes. So again, it speaks to that, the Institute for Healthcare Improvement's triple aim. And it also plays into our fourth aim, which is, you know, making sure that there is joy in work for healthcare professionals again. There's a clear differentiation in systems of care that do not speak to that fourth aim, and really aren't pursuing the triple aim in policy. And in systems like that, healthcare simply becomes exponentially more expensive because there is no calculation of return on investment. It's just simply, you know, the purchasing of more tests and, you know, more MRIs, more CT scans, more X-rays, more blood and lab work. You know, and it's really not even looking even a little bit at a person's mental health and stress. So when that's left out, we leave, you know, the human out of the equation.
And it contributes to the turnover that happens so consistently in healthcare. And I mean, it's amazing when you run across somebody who's been in healthcare for 20 years and they still love what they do. You wonder what motivates them. And oftentimes they found some secret sauce that allows them to consistently do what they do. But what if more consistently across the board, you had folks who were able to meet that fourth aim, and organizations that were able to invest in their working population to increase that fourth aim. So I 1000% agree with you as well.
Yeah, we're starting to see some good models that are emerging. Cleveland Clinic is doing some great things, but you know, my dad recently had to have a quadruple bypass surgery on an emergency basis. Wow. And I looked at the research because I've done training and I've also taught courses on working with families in terms of, you know, caring for individuals who are recovering from a cardiac bypass graft surgery, which we call a CABG. And so, you know, for individuals who are recovering, there are a lot of mental health, you know, indicators. One big one is depression, but another one is sleep. And after a surgery like that, you get very little sleep and there's a lot of coughing, and you lose so much of your independence after a surgery like that. You can go from, like my dad, 70-year-old who was completely independent and playing pickleball one day to completely and utterly dependent on machines and humans to keep him alive for the next, you know, several weeks. And he's still recovering, you know, he's doing better now. But one of the things that I was reading that the Cleveland Clinic was doing, and that was, you know, just a standard practice in Europe, is this thing called a prothorax vest, which is essentially, it almost looks like you're a police officer, and, you know, it buckles in and it has these pads that go on either side of the sternum to really splint it, because it's a bone that needs to heal and it needs to be splinted. and the outcomes were just, incredibly improved based
Wow.
on this one thing. And so we asked at the hospital if they were using a vest, and they said no. And, my dad's sternum ended up coming apart. He had to have a second surgery because his sternum came apart because of the coughing that happens. Um,
Uh,
so my sister lives in Ireland, and she happens to know, she's a veterinarian and a surgeon herself. And so she ended up learning that she could get a hold of a prothorax vest from one of her friends there, got it, brought it over when she came to help, be part of the caregiving team. And, my dad's outcomes since having that vest have just been completely different. So we asked, hey, if they're doing this at Cleveland Clinic in the United States, and, it looks like there are ongoing trials that are really proving that the evidence is clear, that health outcomes are a completely different story for people who have the vest in all of the key indicators for a successful CABG surgery. And every provider that we've talked to just said, oh yeah, that's really neat. I wish they had those here, but they just shrugged their shoulders. I can't do that. I'm a DBH.
yeah.
My sister definitely wasn't okay with that, knowing that it's something standard in her country. And, my mom as primary caregiver was going, wait a second. We've worked our whole lives. We've become Medicare eligible. Why isn't this happening for us? And so, that's really just one of those ways that we as doctors of behavioral health need to say, hold on, are you looking at this return on investment? Because my dad had a readmission, he had to have a second surgery, he had to have a 5-day hospital stay, and then he had to have an extended 14-day stay in a cardiac rehab hospital following the second surgery. And they weren't even going to let him do that. We had to basically push the issue with case management because I said, there's no way he can go home. He can't even get up and out of the bed by himself. They want to send him home. So these are just things that, a DBH in a family can make a huge difference. But, as far as the return on investment, it makes no sense to not have something as small as a little buckle vest available for the number of surgeries. CABG surgeries are, oh my goodness, they're happening 100. Some of the surgeons are doing, 10, 15 a day.
Wow.
Just in our area alone. So
well,
yeah.
first and foremost, my sincerest prayer to your family and all of that. That's a lot to manage. But a lot of your advocacy speaks to the leadership that we're able to exhibit when you have the information. Some leaders become leaders by accident, and others are leaders because they have information to be able to find answers or find things that are either outside of the box that aren't being utilized. And that kind of leadership quality only comes from consistent research, comes from being able to be conversant in different arenas like that medical literacy language, and being able to be interdisciplinary. And so those skill sets are built and developed mostly when you take the time to nurse them, and like a DBH is.
Yes, you're right. You're right. And, of course, when it happens to you personally, it feels like a much fiercer, way of having to advocate for your own personal family member or for yourself. But I immediately went to, what about every other patient on this floor? They don't have a sister in Ireland that can bring this vest for them. What are you doing for them? And so I don't know if that's the DBH in me or just the human service professional and, counselor in me. But I didn't sleep for a couple of nights just thinking about everybody else on the floor with my dad who didn't have that vest and whose outcomes were likely to be much poorer because of it. And there were certainly people in that hospital, my mom and my sister and I had to take turns because we're still under COVID rules, and the hospital only allows 2 visitors per day, period, not at a time, per day. So if my mom and me walk in at 10 o'clock in the morning when visiting hours start, that's it for the day. So my dad had 3, 4, 5 different family members jockeying for position to go in and help improve his mood and advocate for his needs. Whereas there were many other people on that floor who had no one with them. And we kept saying, my God, what are their outcomes going to be?
Mhm.
So you're right, 100%. It's definitely something that you can't forget once you begin, studying as a DBH, certainly. But certainly I think it's a value that we need to be able to say, look, United States, we have this incredible way of advocating both for the patient and the family and for the return on investment. So, I just recall it at a speaking engagement when Nick Cummings said the Affordable Care Act is supposed to make healthcare affordable, but it did nothing to control healthcare costs. It's not looking at return on investment. It's simply saying everybody should have healthcare, but it's missing the boat entirely on saying we have to make sure that we're mandating that the return on investment research be there before we just send all of these people for tests. And where is the psychological and the behavioral health and lifestyle management in the Affordable Care Act? It's missing.
Mm-hmm. Wow, that's such a critical point. And the more I hear about what Dr. Cummings has said, it makes me wish I met him more. But I'm so glad that I get to interact with Dr. Cummings, Dr. Janet Cummings, because the message still gets to live on, and I get to hear some of those significant statements like you just made, because it is very critical that we as DBHs and really just healthcare professionals are very conscious about what it means to be a part of the system. That we're not just independent cogs in a wheel; we are literally interdependent cogs. That we require each other, and this system can only improve if we have each other.
Yes.
And I love the idea of being a disruptor, because I think I've been a disruptor, a quiet one, most of my life.
Clearly.
Yeah. But it makes sense that if one of the cogs are creating a problem, then whoever runs the system has to go to that cog and say, well, what's the problem? And then we go, let me tell you, this is how we see it, and this is what needs to be done. And if we've got that credential behind us, it really proves our voice to be significant, and things change.
Right. I love everything about what you just said, Napoleon. I really do. Because as I look at healthcare in general, what I see is that when there's a problem in the system, it's the bean counters who are being the problem solvers rather than the people who are in the trenches delivering and working with patients each and every day. Yeah. And we're looking at the clinical outcomes as well as the service delivery, we're looking at that assembly line on a day-to-day basis. So we're most likely to see that cog that is malfunctioning somehow. And we're most likely to be able to say, we think this is what it's about. But instead, bean counters have been called in to fix a problem that they don't know anything about that assembly line, nor the products that are on the assembly line going forth. They just know about counting money. And that's a huge, huge issue we have to resolve. And so I really appreciate the work that you've done, because I think, just in protecting the ability to continue to practice and deliver services in Michigan, you said we're not going to allow this to, be left in the hands of people who don't know what they're talking about.
Mm-hmm. My mom told me when I left the house, she said, well, go do something. And so I did.
Good for you. I love that. And go do something. So I did. I love that. You've quoted your mom several times. You better call her after we talk today.
I will. I texted her early this morning and told her girls miss her. She's out vacationing, enjoying life.
Good for her.
Yeah, and she's loving it. And so I had to tell her girls are missing her.
Her girls are missing her. Well, now you can, text her, not to, make her answer a phone call on her vacation, but just to say, hey, Mom, I cited you 3 times in the podcast. Moms need to know that stuff. I'm a mother. If my son cited me, I would be so proud.
Well, my mom, she goes, because I it's all the time. I come from a single parent family, and so she literally, she had all these idioms and these quotes and these statements that were that kind of served as, when those statements that come from a dad that say, father know best, she had those statements and those kind of sufficed, if you will. I mean, I know a whole lot of therapy helped, but literally those statements were like those key things. And so I held on to them, and they were great. And so anyway, she every time I'm doing something, she's like, well, did you tell me that you did it? And I'm like, yes, mom, here, I'll send you the link and on your smartphone. And
yeah, exactly. I love that. I really do. And I think it's important. You mentioned right off the bat, that that you did not achieve this alone, that that the investment in people helped you get to where you are, and also helped you achieve and accomplish the awards that you've won. And I truly feel that is something that we all need to have, that ability to say, look, we are the products of what's been invested in us, and that too is important. So going back to the idea of having that strong professional organization, that just means that we can even, we have more resources to invest in young professionals, because we need upcoming professionals to know what we know. And, we need to be able to share our experiences and success formula, with them.
Mm-hmm. And truthfully, beside everybody who does something great is somebody who gave them the space to do that great thing. And my wife was, I'd be remiss to even mention the fact that she was pregnant with twins during that time, where I had to shuttle back and forth to Lansing. And those were some really long days and some difficult times. And I don't know how the lady's just made of, just marshmallow, but she's made of steel in her spine.
Yeah.
And she was able to do it and deliver. And there's another story that goes along with that. But she's done a remarkable job. And so I appreciate everything that she's allowed me to do. And it's been a fantastic ride.
Well, I love hearing that, because we're only as strong as our family, home, and the structure of our home has to be solid, so that we can grow, deep roots in the earth and reach high with our branches and leaves. So, I think I mentioned, at the beginning, that my husband does the editing and production of our podcast. He's an incredible video producer here in Phoenix, and he does a lot of work for us for free. He donates a lot of it. And when I started my DVH, we had a 5 or 6 year old, and he said, it's fine, you go. We actually had a really small little 2-bedroom condo, and we set up an office in the garage. He said, you go in the garage and close the door, I'll bring you some dinner, and when it's time for Sonny Boy to go to bed, you'll come in, you'll do the reading books and everything and go to bed, and then right back at it. And, that's how we got through those years. And I always say to him, if I hadn't had you, I definitely would not have been able to do this, as, I wouldn't have been able to do it as a single mom, for sure. Or it would have been 1,000 times harder. So you're right. Absolutely. We need to have strong, good, huge, high quality relationships. And that is, a 50-50 thing for sure.
Absolutely. And Michigan doesn't have those kind of garages, but we got basements. So that works.
Indiana, boy, do I miss my basements. There are very few houses out here that have a basement, but yeah, the Arizona community uses their garage like the Midwest uses their basements, for sure. All right.
It's much cooler though.
Yes, no kidding. Oh my gosh. My parents never had the need for central AC in the summer, because the basement was always so cold. But in the wintertime, that was where our wood stove was. So got that wood stove cooking, and the rest of the house was fine.
There you go.
All right, Napoleon. Well, listen, thank you so much for your time. This has been a great conversation. I'd love to follow up with you, as you continue to serve in professional organization, and certainly as we explore different professional organization options as DBHs. I think it'll be an ongoing conversation. So thank you so much for your leadership and advocacy.
Awesome. Thank you very much. I love the conversation, and I can't wait to be a disruptor even more.
You're already there, buddy. Keep doing it and do it more.
I will.
All right. Well,
Okay.
We'll talk again soon. All right.